Our next speaker, who I'll say a few words about, we'll be hearing from Dr. Annita Sawyer, and she is a assistant clinical professor in our Department of Psychiatry, a supervisor of psychotherapy. She has a private practice full-time. She graduated cum laude from Yale College. She obtained her PhD here at Yale. And she's an author. She's written several works. She's received literary awards for them. In the last few years, she has begun sharing her own personal journey through issues of mental health and struggles with our mental health system, particularly at the time when she was doing that. And she is here to very bravely share her story. I'm so grateful to her as someone who is part of our faculty to be here giving a personal, first-hand account of what it's like to face some of the challenges that we speak of here. She has written a memoir of her experience. She is currently working with publishers, or working with the process of establishing which publisher will publish this work. Her current version of the memoir is for sale here. So in terms of conflict of interest, she's not making any money off this, but there are bound copies of the memoir, and that is also over in the downstairs on this side. So people are welcome to take a look at those, and either way, I would strongly encourage you to keep an eye out for her memoir when it is published, which will, I think, be forthcoming within these next few years. So I would like to invite, thank you very much, Annita Sawyer, Dr. Annita Sawyer.
Can you hear me? I'm honored to be here. I can't imagine a greater affirmation than the opportunity to speak and to be heard. I'll look at short and long-term consequences of a diagnosis of borderline personality disorder and other serious psychiatric conditions, using myself as a case study. I appreciate that you've just heard a list of my accomplishments, so I don't need to tell you myself. But I've always begun by referring to my public record, explaining that I graduated from Yale and the first class with women, et cetera, et cetera. And then adding that I've been married for almost 44 years, that I have 2 adult children and 2 grandchildren. You can easily see the defensiveness. Despite my adult accomplishments, despite my growing confidence over time, a part of me continues to worry that when I tell you I spent most of the years between ages 17 and 23 in 2 psychiatric hospitals, you'll feel that there's no need to listen further. You'll be inclined to dismiss my words, if not run in the opposite direction, as I feared when I was younger. My first public presentation was in 2005 as a co-presenter with Dr. Michael Stone at Cornell Columbia Psychiatry Grand Rounds in New York City. Dr. Stone, a member of Otto Kernberg's Personality Disorders Research Group and a significant researcher in his own right, was presenting the results of his study of hospitalized patients in New York City from the 1960s who fit his criteria for borderline personality disorder. I organized my talk around my need to make clear that Dr. Stone was mistaken to include me in his study. I don't think I'm alone in believing that mental health professionals, no matter how compassionate and understanding we might be with our patients, are among the most prejudiced individuals when it comes to our own or close family members' psychiatric conditions. Many of us struggle with shame and strive to keep our difficulties secret. Prejudice, by definition, transcends reason. I am here to challenge this attitude. Michael Stone and I had first met over 40 years earlier when he was beginning his second-year residency on the same ward of PI, the New York State Psychiatric Institute affiliated with Columbia, where I was an inpatient. I was 21 years old at the time and had been institutionalized for almost 4 years. Dr. Stone's ultra-long-term follow-up study included many dozens of patients he had classified as borderline from PI and similar institutions in the 1960s and 70s. Some of these patients had made it, others had not. A number of them were successful, many were dead. In 1960, when I was first hospitalized, the diagnosis assigned to me was schizophrenia. Much of the treatment I was given made me worse, and for many years, my prognosis was described as extremely poor. Nevertheless, as you can see, I was one of the very lucky ones who survived and succeeded. But I always have trouble keeping my voice. How is it that I am successful and not dead? What enables one person to overcome significant adversity while the next one can't? And most important, how can we, as clinicians, as patients, I hope you don't mind, but I'll continue to use the term patient for the person being treated, because that's how I used to be. How can we influence the outcome? By describing what happened to me, I'll give you some possibilities to consider. I bring a unique perspective. I can speak both as the doctor who seeks to heal and as the patient who surmounted the odds. Whether you are the therapist or the patient, a parent, a sibling, or a close friend, I offer my story as encouragement, as a resource for sustaining yourself during those times when you might feel overwhelmed and want to stop working so hard. That's when retreat to stereotypes become tempting, because I've been part of both worlds. As desperate patient and experienced therapist, I speak the language of each one. I want to offer help with translation and to facilitate understanding. My story illustrates how easily in the early 1960s, an anxious, dissociated, severely suicidal adolescent could have been misdiagnosed with schizophrenia and then could have been given shock treatment. This happened because trauma was not well understood, because sexual abuse was barely acknowledged, and because the available treatments at the time determined the diagnoses given. This last remains true today, although some of the treatments and diagnoses have changed. If I have one message to offer you, especially for therapists, but for families as well, it is to pay mindful attention, to listen, and learn the language of the patient rather than trying to apply what you think you already know. The poets and artists and anthropologists among you, those who are comfortable with ambiguity, who are open to unusual alternative worlds, may find ways to communicate with difficult individuals that enable them to feel understood. My concern about diagnostic labels is that they can too easily become a refuge from the pain, humiliation, and frustration, as well as the satisfaction and joy of grappling with a real person. Diagnosis is useful for setting the scene, but it does not write the script. I speak as a clinician who certainly has made my share of mistakes. I know there are not always answers, and that what we believe and trust today may prove misguided, even harmful tomorrow. But I'm passionate about the danger of making assumptions rather than paying attention, accepting stereotypes rather than doing the hard work of being open to each unique individual. Again, my message is this: never sit back and think you have it all figured out, but pay attention, keep an open mind, and don't give up. I also speak as someone who was a very close call. Now, over 50 years ago, in 1960, I had just turned 17 when I was admitted to a prestigious local psychiatric hospital and given a diagnosis of schizophrenia, other type, depressed. I'd swallowed 14 aspirin a few months earlier. This time, my mother had read in my diary that I was going to drown myself during a Memorial Day weekend at the beach with my high school friends. It was so long ago that one report gives me a diagnosis of dementia praecox. I'd been active in my high school. I'd had leading roles in school plays, was an editor of the literary journal, worked on the yearbook, was active in the honor society, etc. My friends were what today we'd call the smart alternative students. Yet for several months prior to the hospital admission, I had been shrinking. My handwriting got smaller and smaller. Gradually, the differentiation between lowercase and capital letters disappeared. My English teacher told me he'd no longer read my papers if I continued to write like that. My voice volume diminished until I was almost inaudible. I stopped speaking in the first person. I couldn't say the word I. In the hospital, I admitted I wanted to die, but I was unable to articulate my reasons for this beyond saying that I was crummy and bad. My thinking and ability to express myself had shrunk along with my voice and my handwriting. All I wanted to do was disappear. The hospital psychological testing report referred to my slipping into a quicksand-like illness, deeply depressed, with suicidal preoccupations and fantasies. Along with suicidal ideation, my symptoms included insomnia, depersonalization, and derealization. We would say now that I was very dissociated. I was described as shy, fearful, obsequious, dependent, and infantile emotionally, while my inability to express myself was identified as stubborn resistance and withholding. My inaccessibility annoyed and frustrated the psychiatrist treating me. Less than 2 weeks after being admitted, I was started on a course of 25 ECTs. I began to experience hallucinations. My nightmares increased. During the day, I remained passive and withdrawn. If I had arrived 20 years later, in 1980, let's say, I would probably have been diagnosed with borderline personality disorder, another critical diagnosis associated with permanent disability, which had achieved prominence by then. 20 years after that, in 2000 perhaps, these same symptoms might have led to a diagnosis of bipolar disorder, although some few might have suspected PTSD. I might be given any of these diagnoses if my young self turned up today, depending on how much information was available and who was diagnosing me. But focusing on pathological symptoms in order to arrive at a diagnosis can interfere with seeing clearly the whole person in front of you. It makes it easy to lose heart and to miss positive resources that might serve as anchors for the therapeutic alliance and provide fuel for the creative energy necessary to sustain that alliance. I believe that a diagnosis can be useful because it provides an organizing framework, but we mustn't forget that it is our construct, not some objective truth. Giving an adolescent, or anyone for that matter, a psychiatric diagnosis has serious consequences. The most immediately obvious is that diagnosis informs treatment, and the wrong treatment can be harmful. For an unformed adolescent, you are also influencing in a profound way their intimate self-definitions, a way of looking at themselves that will likely take hold for the rest of their lives. That is no small effect. I was discharged from the hospital almost 47 years ago, yet my defensive introduction shows you I still need to make sure no one thinks that my psychiatric history means I'm a crazy person without authority to say what I have to say. My point is simple. Stigma is real and shame sticks. In the 1950s and 60s, schizophrenia was a very frequently applied diagnosis. It was used for out-of-control, rebellious, dope-smoking teenagers whose parents didn't know what to do with them, and it was used for withdrawn, socially isolated youngsters who were depressed and suicidal. Some, like myself, although I didn't know it consciously at the time, were fleeing abusive situations in their homes. Treatment for schizophrenia included medication, often electroshock treatment, and sometimes psychotherapy. So over-medicated teenagers were one consequence. For many of us, it was also shock treatment, which affected our brains and destroyed short-term memory. And for me, the shock treatment itself was traumatic. I understood that ECT induced a seizure by sending electrical impulses into the brain. I figured that all it took was a slight miscalculation to end up electrocuted. As a consequence, I approached every single treatment terrified. I was sure I was about to be killed. I showed no initial improvement with the ECT, and I developed some symptoms in the hospital that had not been evident prior to my admission, such as hallucinations and stuttering, serious clumsiness, and eventually seizures. I looked like I was 12, although I was 17 when I was admitted. I was smart, but I talked pretty dumb, expressing myself more like a 6-year-old than a high-achieving youngster of 17 or 20. I was determined to die, not to escape my own pain, but to atone for my sins. No one stepped back to look at these as valuable clues, as messages that I could not communicate with words, yet was refusing to relinquish. I was acting out in metaphor what I could not know or say directly. Similarly, on the level of metaphor, the hospital doctors delivering shock treatment were unwittingly repeating the abusive behavior I was fleeing, reinforcing the message that I deserved to be punished and should never speak about or even recognize what I knew. After several dismal months, I was assigned to a new young psychiatrist who was lively and liked me. Slowly, I began to get better. I had been admitted in May, and I returned to school to complete my junior year the following April, commuting from the hospital. I returned to live at home on an extended visit, a 6-month pass, in June, just a year after my admission. That fall, I was elected president of my high school National Honor Society. I had a leading role in the school play. I was an illustrator for the yearbook. I took honors classes. Then, less than 2 months into my senior year, I began to have seizures and dissociative episodes in school. I began to slip. After about 7 months at home, in January 1962, I was readmitted to the hospital, intensely suicidal. My condition had deteriorated significantly. All my apparent gains had been lost. I was given shock treatment, more shock treatments, and deteriorated further. I began to act out in increasingly blatant, self-destructive ways. Eventually, after 3 more courses of ECT, adding up to an overall total of 89 shock treatments before I was 20, I continued to lose ground, and the hospital decided that they could do nothing more for me. I was identified as unimproved. Luckily for me, my mother's best friend from grade school was now married to the lieutenant governor of the state of New York. So I was transferred to PI, a state hospital, and Columbia's teaching hospital. The director of PI made clear in a letter that he was accepting me because he was required to do so, and really, and not to hold him or PI accountable if I failed to improve, which he anticipated, given my dangerously suicidal condition and my extremely poor prognosis. By this time, I had lost almost all memory of my life prior to the hospitalizations. When I arrived at PI, I was 20 years old, and I couldn't answer the question of how many weeks were in a year. At PI, I was not given shock treatment, which was a relief, but I was assigned to a psychiatry resident with whom I couldn't connect. We didn't respect one another. I continued to act out, alternating between passive withdrawal and episodes of smashing my head against the wall. I swallowed glass, I burned myself with cigarettes, scratched my face, bit my hands, and pressed them against radiators to burn them. I held my breath until I passed out. I had nightmares and screamed in my sleep. I had lost pretty much all memory of my early years. What remained was only a global sense of fear. I was seriously dissociated, dominated by feeling completely unreal myself and experiencing the world around me as unreal as well. I thought I was evil. I hated myself and assumed everyone else did too. I'm sure at times that the staff experienced me as completely impossible. I was often beyond reach. After I had been at PI for about 6 months, I made a significant suicide attempt while I was home on a weekend pass. After that, I didn't go home, even to visit, for close to a year. In July 1964, after almost a year at PI, I was assigned to a new psychiatry resident. Stanley Heller was someone I liked and respected. I thought he was handsome and smart, and he talked to me. I felt that he took me seriously. He didn't talk down to me or lecture me. His sense of humor matched mine. When I made stupid puns, he laughed. When I told him that evil garbage stank and should be eliminated, he told me he knew someone who looked for treasures in garbage. One person's stink is another's perfume, Dr. Heller noted, astonishing me. Humiliation and shame could be interrupted, if only briefly, by my admiration for his cleverness. I continued to act out in self-destructive ways, but his response to me was direct and real. "What a pain in the neck," he said once after I'd battered my head yet again. I had to laugh at myself. In the spark of a good joke, we were peers. We connected. He was not blaming or intrusive with interpretations of my motives. Instead, he was straightforward and looked at what I had done and asked, "Why now? How come? What are you doing?" As if he thought there were understandable reasons for my actions that we could figure out together. When I did something particularly dangerous, he showed that he cared that I had been hurt, and he expressed his anger in a way that showed me that he worried about me. I had been unlucky in that I was misdiagnosed and the treatment traumatized me, but I was lucky that in the late 1960s, along with medication and shock treatment, in the teaching hospitals, there was an enormous investment in psychotherapy as treatment. So eventually, I was able to connect with Dr. Stanley Heller and to begin to find myself. A colleague asked me if I could explain how, as a patient, I differentiated the psychiatric residents I respected from those I did not. I think I can safely speak for most of us at the time when I say that I could sense which residents were afraid of patients and which were comfortable with themselves and with patients as fellow humans. I could tell who was speaking past me, mouthing empty phrases without noticing if I was listening, closed and aloof, afraid of being contaminated if touched. The finest therapists understood their work to be a collaboration with each patient. They weren't afraid to journey together through an unknown and possibly dangerous land. Subjectively, when I felt understood and respected, that is, taken seriously, which was infrequent, I was grateful, and in return, I gave that person, doctor or nurse, enormous respect. They also got my loyalty. I gave them room to be imperfect in subsequent interactions, as long as they were honest and real. Feeling understood is the essence of connection, and ultimately, it's this connection that carries healing. An example of this ability to connect comes from a set of interviews I had with Harold Searles in late 1964. Harold Searles was an internationally recognized psychiatrist, considered a master clinician who pioneered countertransference in treating psychotic and borderline patients. At the time, he was the clinical supervisor for my psychiatrist, Stan Heller. In the first interview, Searles made references to my shrinking, self-effacing demeanor and behavior on the ward and told me I acted like I wanted to be a saint. I don't remember that interview beyond my thinking that he was an uncomprehending jerk. But there was a second interview, And that one I've always remembered and credited, and I knew this even at the time, somehow, with changing my life. In the second interview, Harold Searles referred to my interest in being perfect, the saint thing, and then he remarked that I appeared to him like a frightened young fawn, a deer in the headlights. My frozen innocence and fear made him feel like a dirty old man, he told me, and this made him feel so bad about himself that he wanted to kill himself. One remarkable feature of this exchange, as I would later understand, is that unconsciously I had communicated and he had received the essence of the truth that was unknown to me at the time. My paralyzing fear was indeed connected with a dirty old man and was driving my obsession with suicide. A transcript of this interaction might appear bizarre or quite inappropriate. However, for me, although I couldn't explain it consciously, Dr. Searles made contact. I felt connected and understood. The life-changing aspect was the idea that I could affect the feelings of someone else, especially, in this case, a respected authority. I had caused him to feel something. For someone who felt as if she floated alone in the universe, unreal and completely without influence, this was a new concept. That night, following the interview, I told the other patients gathered at our informal evening coffee discussion group what had happened. He said I made him feel guilty, like a dirty old man, like I was some kind of saint. Can you imagine? Hell yes, said one. You're always doing stuff for other people. Yeah, chimed in another. You do that right here. When someone sneezes, who's the first to go running for a tissue? It's sickening. Don't you realize you make us feel like we're not as good as you do when you do that all the time? Like you have to be better? Yeah, I feel useless sometimes, like you have to get there first to help. One after another, my friends, and even some patients I hardly knew, gave examples of my oppressive helpfulness. I'm still a little like that. At first, I felt bewildered, but I got it. I think my awareness that I had an effect on other people began my healing. I experienced myself differently. I observed myself interacting. Working with Dr. Heller, who had laid the groundwork and whom I trusted as my guide, I was on my way. After I turned this important corner, what registered with me were the times when Dr. Heller stepped beyond his white coat, if you will. They really wore white coats then, and treated me as if I were a reasonable person, not a mental patient. I suppose as translator, I'd say that when I refer to being seen as a mental patient, it meant I felt I was being treated as a less than human object. But Dr. Heller spoke to me as one whole person to another, and he noticed the healthy part of me. Gradually, I could tell he believed in my strength. He believed that I could make a life for myself outside of institutions. I knew he was showing me how healthy people interact. Toward the end of that second year at PI, when the July rotations were approaching, I realized that I might possibly remain Dr. Heller's patient if I got my behavior under control. Similarly, I understood that if I failed to control myself, I'd have no chance to continue treatment with him. I managed to succeed well enough, and I remained his patient through the rest of his residency. A year later, I knew I had to be well enough to be discharged in order to continue to work with him after he left PI and opened his private practice. I moved out of PI the day before my 23rd birthday, about 6 weeks before July 1st. Dr. Heller and I continued to work together for the next 5 years. I was employed at several retail and then clerical jobs during the year I was leaving PI. As a patient in a state mental hospital, I was eligible for state services, and through the Department of Vocational Rehabilitation, I was sent for psych testing. Although I was still diagnosed as schizophrenic, I was considered bright enough for college, so they sent me to school. Those were really the good old days. The next year, I began college at the School of General Studies at Columbia. At school, I met the man who was to become my husband. We fell in love after a courtship developed from our intellectual kinship. We reveled in discussions about our sociology class and the concepts and theories we were learning there. 2 years later, I married him and moved to New Haven, where he was going to attend graduate school at Yale in sociology. Yale College was accepting transfer students for the upper classes as part of its first year as a coeducational college. Of course, I was rejected as a transfer student. However, as a Yale spouse, I was allowed to attend classes as a special student. I spent most of my junior year walking around with a giant chip on my shoulder. I should have been grateful, and in many ways I was, but all I saw were beautiful young women whose applications had not been rejected, and I was envious. Yale's transition to coeducation was difficult, and many women left. A year later, Yale reopened admissions for transfer students. I applied again, and this time I was accepted. To celebrate, Dr. Heller brought a half bottle of champagne to our session, and we toasted the momentous occasion. He was afraid to tell his supervisors. It was a marvelous affirmation of my assertiveness and adult accomplishment. In 1971, I graduated with the first class of Yale women, summa cum laude, Phi Beta Kappa, with highest honors in sociology. This, in turn, opened further doors for me by encouraging people to take me seriously, to give me a chance when other aspects of my history might have made them shy away from investing in me. I was determined to become a psychologist myself, and my journey to achieve that goal also involved serendipity, good fortune in having those who believed in me, and sheer grit and determination on my part, stubbornness, actually. I applied and was initially rejected for a graduate psychology program, and then for the clinical psychology internship. Essentially, I proved absolutely determined. I refused to stop trying until various directors in various programs said, okay, if she wants it this much, why not let her? And then, why not let her do it? And then I did it. For the first 2 years after I was married and living in New Haven, I commuted to New York City to see Dr. Heller. Then I knew it was time for me to learn more about how to be a woman, and with his blessing, I transferred to a female psychiatrist in New Haven. She and I worked together for the next 10 years while I attended graduate school, did my internship, had my babies, and carried out my dissertation. In 1981, after 21 years of therapy, I stopped. 3 months prior to my last appointment, I had a transformative experience while on the way to my session. I suddenly found myself intensely, vividly alive and present. The depersonalization vanished. I was real. It was as if the world suddenly took on color when before I'd known only shades of gray. When I terminated 3 months later, for the first time in my life, I felt I was truly on my own. At the same time, I knew that my therapist was still there for me if I needed her. That fall, I finished my dissertation and was hired by a child psychiatrist, expanding his clinic. I joined him and his partner, the late psychologist Daniel Miller, who became my supervisor and mentor. I've worked full-time ever since, first with that practice and since 1990 on my own. I've spent those years learning from my patients and always trying to understand what it is that leads to people getting well. A few years ago, 40 years after I had been first admitted to the hospital, I seemed to be successful personally and professionally. I'd proven to myself that I'd made it. But I continued to live with what felt like the shameful secret of my hospital experience and the reality that I still had no memories of my childhood, most of my first 20 years. I avoided talking about my youth, generalizing and confabulating when necessary from facts I'd been told or read about myself. Only a few people knew about my history in psychiatric hospitals or my extensive psychotherapy after that. My children were grown and on their own. I decided it was time to find out about my lost life. I was ready to confront my past, so I sent for my hospital records and I read them. As an experienced clinician, I recognized immediately what the doctors hadn't been able to see in 1960. My problem wasn't schizophrenia, but incest. Once I encountered the clinical reality of my early situation, I started to remember what I had assumed had been lost forever. My memory had not been destroyed by the shock treatment after all, but had been repressed or dissociated even before I was hospitalized. I realized I'm a sort of illustration of everything that you've heard, before this about memory, etc. However, confronting the truth of my circumstances via the records profoundly re-traumatized me. I had trouble sleeping and eating. I developed flashbacks and nightmares, was beset with intrusive images, and became very anxious, subject to emotional flash floods of grief and despair. I lost interest in the world around me. I was focused only on finding out who I was and what had happened to me. My various perspectives all came together when I read my hospital records and discovered the trauma in myself in the present. I had known myself as a mature, seasoned therapist who listened to her patients with an informed, compassionate understanding of the whole organic process, accepting the painful ups and downs in the short term by holding on to the big picture. Now, I also knew the immediate, pristine, existential perspective of the same woman who couldn't believe what was happening to her in her own present life. I was caught off guard when I read my records. I had no idea I could be so unsettled. I had thought that I was well analyzed and prepared to deal with anything life might bring to me. In fact, I was pretty naive. Throughout this time, I continued to work full-time in my psychology practice. I had my own individual therapy, and the psychologist part of me was observing and aware of what was happening to me. But the need to pull myself together in order to be present and true to my professional commitment in my office is an important part of how I survived as well as I did. Each day, no matter how dismayed I felt, I had to summon my adult strength so that I could be present for the people who needed me. Because I was working with a skilled and experienced therapist in my own psychotherapy, and recovery is an orderly process, with time, I emerged from the other side. My symptoms receded, and I regained an interest in the world outside myself. Some of the emotional intensity of my experience, even though it was relatively recent, disappeared. And, as with childbirth or a terrible nightmare, only the intellectual awareness that I had experienced some feelings beyond ordinary comprehension remains. The essence of my interest in describing these things to you is to emphasize that we always have to pay mindful attention. What happened to me initially was a failure to pay attention, and what ultimately enabled me to recover each time came from informed, careful, exquisitely personal attention. The diagnoses and treatments may change. Today, it may be borderline or bipolar rather than schizophrenia. And the treatment may be powerful pills rather than shock treatment. But with today's pressures, there will always be the temptation to think that you know the answer without really looking at the particular individual in front of you and to put him or her into the category at hand because you have the latest drugs to prescribe or the newest therapy to apply. These seemingly innocent errors can have devastating consequences. And even if you have the right diagnosis, everyone needs to be known as a whole, unique person. No one cures a diagnosis. What my guiding clinicians had in common was their own self-awareness and self-confidence. It took paying attention, looking me in the eye, and not being afraid to learn who I was. Each of them was authentically him or herself. They were real. They had faith in their own ability to act spontaneously in the moment. Often the moment was one of humor. In sharing a play on words or a sarcastic observation about someone else, even about me, I was just one of two adults enjoying each other's company, secure in that brief exchange that we were truly communicating. For those seconds, I wasn't alone in the universe, unreal and unattached. Those seconds were precious, and I remembered them. These therapists also showed that they cared. They weren't put off entirely by my annoying mannerisms. They chose not to dismiss me as manipulative, but to see the frightened child underneath. We don't do things for no reason, I tell my patients. I was a scary and frustrating patient, but I was trying to communicate. The therapists who make a difference didn't overlook the messages in my behavior or disregard my tremendous neediness. They were very patient. When I hurt myself, they got angry in a way which communicated that their anger had to do with their not wanting me to cause myself more pain. And when I got better, they believed in me. Although, along with compassion for my pain, they appreciated my strength, my intelligence, and my quirky sense of humor. And they each have remained a part of my life, concretely affirming my value as a healthy adult. I didn't have to stay sick to know them. This is one of the most important aspects of the therapy I learned from my mentor, the late psychologist Daniel Miller. The philosophical understanding that defenses, our symptoms, personal style, and perceptions of the world are rich sources of information about old relationships and reflect past and present strengths. This is the essential model of wellness, of respect for survival, and focus on the tools that make survival and growth possible. The stubbornness that had me relentlessly pursuing my death, that led my earlier psychiatrists to characterize me as withholding or resisting shock treatment, is the very same determination that has led to my professional accomplishments, my writing my book, and my speaking here today. As Stanley Heller recently reminded me, what really matters is how well you are, not how sick you are. I didn't suffer from schizophrenia. I may or may not have had a borderline personality disorder. These and several other diagnoses share many symptoms with complex post-traumatic stress disorder, which I did experience twice. However, to focus only on symptoms or on PTSD itself is a trap. It's by setting labels aside, by paying attention to the person right there and holding yourself open to possibility that you can save the lives of people like me.